A big thank you to TACV and the CDC for funding this program. Hoping that a number of you have been on previous webinars, but these are the next ones that are coming in April. And the ones that were on the previous slide are all recorded, and we do have videos available on our website. So Life with Cancer is part of the Inova Shar Cancer Institute in Northern Virginia. Peterson Life with Cancer is our supportive care programming. We provide education and psychosocial support to all individuals impacted by cancer, from diagnosis to survivorship, through evidence-based holistic care at no cost, no matter where treatment is received. So it's really important that folks can come to us to receive care, whether they're treated at Inova or not. We are co-located in all of the Inova Shar locations, and we also have our flagship location in Fairfax, Virginia. Like I mentioned, many of our programs are free of charge, and we're able to do that from incredible donations that we receive from the community and the support of Inova. We also have a specialty shop at Inova in Fairfax, Virginia, that has a number of sexual health products, but also bra fittings, breast prostheses, lymphedema supplies, wig services, and post-surgical garments. So certainly if you're in the area, feel free to stop by. We'll be answering all questions at the end of the presentation tonight. Typically we use the Q&A function, which we won't have access to tonight, but if you can put your questions in the chat, Becca and I will be collecting them, and we'll make sure that Sharon can see them. And if you do not have your name listed on there, it would be really helpful if we could collect your name just so that we know who's here and we can get out a survey when we're done. And just a reminder that the information presented today is for informational and educational purposes. It shouldn't be treated as medical advice. Certainly you can talk to your provider if you have specific questions related to your own situation. Okay, so I am incredibly excited to introduce Dr. Sharon Bober. And yeah. Okay. All right, so Dr. Bober is an institute psychologist at the Dana-Farber Cancer Institute in Boston, Massachusetts, and is an associate professor in the Department of Psychiatry at Harvard Medical School. She is the founding director of the Dana-Farber Sexual Health Program, a multidisciplinary program that focuses on sexual recovery for individuals and couples after a cancer diagnosis. The program serves survivors of both adult and pediatric cancers. Dr. Bober's research interests focus on cancer survivorship, quality of life, and developing interventions for sexual recovery after cancer. I will just say, as a sex therapist myself, Dr. Bober is someone whose work I have followed for a long time. She has really set the gold standard for sexual health and oncology care, and is a trusted expert, researcher, and writer in this area. And I'm certainly thrilled to learn from her, but really glad that we will all have the opportunity to just hear and learn how sexual health is impacted and the distress that that can cause, but also ways that there can be help and interventions for that. So, Dr. Bober, thank you for being here. I will pass it off to you.
Thank you so much for that very kind introduction, and I'm really happy to be with all of you here this evening. I'm assuming that we're all going to just thinking that this is not a webinar, it's sort of a Zoom thing. I know folks can hear me, but to say that at the end, I'm also happy just to have some Q&A and conversation, because I know that you know, we're able to do that. So anyway, I realized that this is part of a big series. There are so many different pieces to talking about sexual health. Tonight, we're really going to focus, I think, around this sort of the issues of emotional distress. But I really want to put this in context, and just to say that as we all can appreciate, sexuality, sexual health is truly at the intersection of physical, emotional, and social well-being, right? Interpersonal function, all within relationship to sexuality. And when we think about, the WHO, the World Health Organization definition really only put out there in 2006, which is not that long ago, where really the point was made that sexuality is certainly a central aspect of human emotional well-being, human well-being over the lifespan, and that again, experienced and expressed not just in behavior, but in how we think, how we feel, our attitudes, our goals, and beliefs. And we know that sexuality is really sort of just multidimensional, and that's really the starting point for me in terms of sort of appreciating cancer-related change in sexual health. Certainly, what we sort of think about in the work that we do at Dana-Farber are really driven by what is called a biopsychosocial model. So really what that means again is thinking about, we just ask folks to mute themselves. Thank you. Thinking about sexual health really at the intersection of all of these domains. And the fact is, cancer treatment and cancer itself can interrupt all of these domains. So obviously, throughout this series, you will hear about all of these different pieces in terms of physical well-being, hormonal changes, body changes, pain, fatigue, all of that has an impact. Emotional distress, negative thinking, motivation, again, having an impact on sexual function, intimacy, communication, all of the social, interpersonal issues, and all about culture too, right? What we assume, what we've learned, our expectations. I will just say that most of the time, if people hear anything about sexual well-being and sexual recovery, it's very much in the context of that physical domain. Use a lubricant, vaginal health, what can you do to deal with vaginal dryness? Really important issues, but very much often disconnected from these other pieces. So, certainly it is multidimensional. And again, today I'm going to invite you to sort of think with me specifically around these issues of emotion, distress, and negative thinking, but really appreciating that all of this is in a context where things are working in concert with each other. None of this can really be sort of plucked out and dealt with, I think, individually alone, appreciating that all of this has to be something we think about together. So, taking a big step back and appreciating that when we're talking about emotion, emotional distress, I really want to just acknowledge that big changes in our life, major events, cancer, also bring up big emotion. I know that, I think we talk about emotional distress sort of in a very sort of vague or broad way, but I think it is not often acknowledged in how you live with some of this complexity in the context of cancer survivorship. I say that because I think there's often a lack of clear conversation about what normal means when it comes to emotional well-being, especially in the context of sexual health and sexual changes. And I also really want to acknowledge that something I call the tyranny of cancer survivorship, which is that there's an enormous amount of messaging and focus on this idea of feeling grateful. And, I'm the first person to acknowledge that, of course, gratitude, and we know having a gratitude practice can be an incredibly useful and helpful component of cancer survivorship. I would also say, from a more existential point of view, no one feels grateful all the time. And the reality is, especially in the context of cancer survivorship, and often with many of the side effects and late effects of treatment, such as major changes in sexual function, people often don't feel so grateful, right? I would say at an emotional level, it is a complicated mix of feelings where we may feel incredibly free and grateful in certain contexts and incredibly frustrated or grief-stricken in others when it comes to feelings of loss or feelings around change. And I really want to sort of invite us to consider the fact that part of that is also what is normal. And I think that, I never am coming from the perspective that the goal is to always be happy or to always be grateful, but to really sort of, one, have a sense of flexibility in terms of emotion regulation, and also a sense of permission to be able to feel a broad range of feelings and to be able to sort of deal with them as they come. That being said, I also want to say a little bit more specifically about real sort of clinical distress, including anxiety and depression, that, if this is something that is, again, clinically in play, meaning that it is actually getting in the way of function, it is getting in the way of being able to allow you to sort of do what you want to do on a daily basis, I think it's very important to seek additional support for that. I also want to acknowledge that when people are dealing with clinical depression, clinical anxiety, it is going to have an impact on sexual function. And that is in addition to or separate from what we know the impact is on cancer from cancer treatment. So for example, when people are really struggling with clinical depression, clinical anxiety, we know that it reduces interest and desire. We know that it has a big impact on arousal and orgasm. People really have a reduction in that experience of pleasure, right? It is hard to feel sensation, have as much pleasure. People often feel kind of numb or tuned out. And we know, for example, if people are having any kind of physical pain, it is intensified when people are also struggling with the depression, anxiety. And people often end up doing things that can also be risk-taking behavior that is not always helpful or healthy. So again, just to clarify, my goal tonight is not going to be to really be addressing the issues that are directly related to clinical depression or anxiety, but just to acknowledge that that may be something in play. And if that's the case, I think it is really important to get, psychiatric or psychological help for those issues. So what I do want to talk about are some of the kind of really interesting and rich sort of interaction between what we know about sexual function and cancer and what we know about the feelings around thinking and feeling. And I want to again, invite you to come with me to learn a little bit about kind of two perspectives that I think can be helpful when we think about the emotional distress related to sexual function. And those are some strategies and some concepts from what we call cognitive behavioral therapy and what we call mindfulness-based sex therapy. So these are really two very strongly well understood and scientifically thoroughly sort of clarified frameworks for approaching, again, emotion and thought. So I want to start with the thought-feeling connection. I want to start with thinking about what we've learned from cognitive behavioral therapy, and then we can apply that to some of the issues around sexual function, but really want to clarify how thoughts directly impact feelings. So this is a kind of a broad kind of rubric or sort of overview where we can just assume that any situation, right, anything that happens to a person is going to prompt a thought, right, is going to prompt what is essentially some kind of interpretation of the situation that I'm in. And when we have a thought, right, when we make an interpretation of the situation that we're in, that automatically brings us to a feeling, right? Feelings are often generated by thoughts. And when we have a feeling, we often do something in response, right? We often have some kind of action, some kind of behavior in response to a feeling. And the idea here is that these things really flow together, right? Often it is immediate, often it is automatic. So we often are not aware, right, of what comes first. Thoughts and feelings are very tied together very quickly to a point that we often talk about what are called automatic thoughts, right? This is something that becomes almost out of our conscious control. And there has been an enormous amount of really interesting work that has been done now for a good 50 plus years, helping people really understand that these automatic sort of thinking shortcuts, right? Automatic ways that we sort of quickly just kind of learn and get into an immediate loop with our thoughts, that we can actually look at those because sometimes those are not always helpful, right? They may sort of come from a place initially that is meant to either protect us or to sort of help us, but they can actually themselves become a little bit of a trap. So I want to give you some examples. I'm going to go through this list, and I know that if anybody's ever done any psychotherapy or counseling separate from sexual health, this might be something that you're familiar with. So a number of clinicians, David Burns and others, have really sort of helped kind of concretize what some of these thinking shortcuts look like. Maybe they're familiar. So for example, we think of something called all or nothing thinking, right? Which is pretty much very just black and white, right? Either it's going to be like the party's going to be awesome or it's going to be terrible, right? I'm going to go to take my first class and it's going to be great or it's going to be awful, right? We sometimes do what is called catastrophizing, again, coming from a place of wanting to protect ourselves, but we often have a capacity to imagine worst case scenario, right? Oh my gosh, it's going to be awful. Nobody's going to show up for the webinar tonight. I'm going to log in. I'm nervous. Nobody's going to come, right? I can imagine catastrophizing. Again, typically that's sort of something we do almost automatically to protect ourselves, right? To imagine what will be the worst case scenario, but it ends up often feeling like we're predicting that, right? We may overestimate or exaggerate the chance that something bad will happen, right? It's definitely going to rain. I am definitely not going to be able to get a date for the prom, whatever it is, right? Fortune telling, assuming that I can predict the future, right? Before I have gotten a test result back or before I have actually gone on that date, I may be making all kinds of assumptions about what's going to happen. I might make some sweeping judgments, right? I might really be overgeneralizing. If I am starting a relationship and I have a date that I don't like, I'm thinking to myself, I am never going to be able to meet the right person, right? It's really hard. Single guys my age, nobody understands me, right? Again, overgeneralizing. And again, one that's often very common, we often do this in relationships, what we call mind reading, right? I think I know what you're thinking. I don't even have to guess. Sometimes it's true, sometimes it is not true, right? All of these are super common. With or without cancer, this is part of human experience. We are sort of prone to making sort of quick judgments, and then we sort of get into these kind of shortcuts where we kind of can think ahead and we know what's happening. But part of the issue with this is that it is on one hand meant to be helpful, but on the other hand, not always helpful. And most importantly, these kind of thinking traps also generate feelings, right? Emotion, which may be distressing. So thinking about that again, very specifically in terms of sexual health and well-being, I want to point out that we get into these tape loops in our head. So I'm an old lady now. I have a picture of a tape loop, but again, can think about that on loop. The point being that we all can have that vulnerability, but it becomes very automatic. So some of the kinds of things that I hear on a weekly basis in clinic, sex is never going to be fun again. I feel damaged. These issues are not fixable. And that's something I imagine that people often hear themselves saying to themselves on a regular basis. I hear people tell me, I can't get turned on the way that I used to, right? This is so awkward. I can't talk about it. Too awkward to talk about. Or who would be attracted to someone with a scar like this? Who would want to date somebody who has a bag? Who would want to start a relationship with somebody who's having trouble getting an erection? Doesn't matter, men or women, right? These are common kinds of tape loops that we play in our head. I guess this is just the price I have to pay for being alive. That sentiment that this is what I have to live with because this was the cost of what it was to be a survivor. So again, I just want to pause and say that, the connection here, right, about these kinds of thoughts is that, like other automatic thoughts, they become automatic. And they are not necessarily true, but they become something that we start to have such a kind of an immediate habit around that we just start to believe them. So those kinds of very automatic thoughts, right, related to sexuality, related to sexual dysfunction, related to change around anything around sexuality, are also part of what we think of often as an avoidance anxiety cycle. So let me give you a little bit more description about that. It is not uncommon that people have some distress related to these common changes, right? Whether it is about what to do, how to talk to one's partner, how to feel whole or comfortable in our body again, lots of different ways, that it is normal that people feel some distress. And that distress immediately often leads to some kind of anxiety, some kind of fear, some kind of frustration, a feeling, right, that is jarring. That immediately takes us to that place in which we talked about that negative self-talk, right? That is that tape loop that all of a sudden you hit play, right? Again, may not be conscious, but is very automatic. And when we're having some distress, when we are worried sex might hurt, I'm not going to enjoy that date, right? I don't know how to feel comfortable in my body. And we start to immediately go into that thinking place, right? With that negative self-talk. The immediate, often common next step is to avoid or to distract or to just escape whatever the situation is which is causing those feelings, right? This is probably the most common behavior that humans do in the context of any kind of distress, is to want to avoid that situation. And the thing about avoidance and that avoidance anxiety cycle is that it is powerful. When we avoid or distract ourselves or get away from whatever that piece is that is making us feel anxious, we immediately have some short-term relief, right? I have patients tell me that they make sure they don't go to bed at the same time as their partner ever, because that moment when they're both in bed and awake feels uncomfortable, right? So just we'll avoid that. The issue with immediate short-term relief and avoidance is that what does that do? Although it is powerful in the short term around feeling like, phew, I don't have to worry about that right now, it absolutely reinforces the feeling that whatever that is that I'm avoiding, I have to keep avoiding, right? It actually increases distress and anxiety in the long term. We worry more about it because we feel like whatever that thing is that we avoided, that we feel better, we have to keep avoiding, right? That is absolutely a cycle that becomes a process which becomes automatic. So those kinds of automatic thoughts that are often very common around changes in sexuality, around feelings and thoughts, are often very directly related to that avoidance anxiety cycle. And in the short term, although it is, again, it can be a relief to avoid some of this, it is a powerful reinforcer of something that in the long term increases anxiety. Okay, I'm going to keep going. The next step when we think about sexual recovery, when we think about managing distressing emotion, when it comes to that avoidance anxiety cycle, is to be able to learn how to move through that, to be able to move beyond that, right? I'm going to give you an example in terms of this framework, but it's not only about sexuality. In this case, this is what we're going to talk about. So I'm going to give you another example, put another process in front of us that may be a counterpoint to that avoidance anxiety cycle. So for example, if I have a goal, something related to sexual recovery, maybe that's learning how to feel pleasure again, maybe that's figuring out how to talk to a partner about what's happened and what you'd like to have be different. Maybe that's just figuring out how to manage menopause. Maybe that's just figuring out how to manage sexual function or vaginal dryness in a way that things feel better, right? The bottom line is that those goals typically mean that there may be some discomfort, right? As we talked about, people may be worried about how it's going to go. There may be some anxiety related to some of that. And the first step is to be able to figure out how we tolerate that, right? How we actually can sit with and tolerate some of that distress. And then again, immediately, what we do with that self-talk, right? How do we reframe that self-talk? Do we just hit play on that tape loop, or do we notice it? Are we able to sort of identify what some of those things are that we're saying to ourselves and really sort of think twice about that, maybe substitute some of that. We'll talk about that next. But the reframing of that negative self-talk is a very powerful step around managing some of this distress. The next step, as you can imagine, is not going to be avoidance, right? It's going to be to say, listen, I need to do something different, right? I'm going to, in an action-oriented way, do something different rather than just avoid. I'm going to have to do some experimenting. I'm ultimately going to have some new habits, right? I may need to create a plan that's going to allow me to do something that I've not done before. I'm going to expand my repertoire, but I'm going to commit to doing something. And that's going to help me achieve those goals, right? That is actually what guides me in terms of some of this shift around moving beyond avoidance. So this is, I think, one framework that we certainly use around sexual recovery, specifically related to managing distress, right, around emotion and anxiety with sexual recovery. So you might wonder, what are some of the specific, tell me what I do, right? What are some of the specific strategies? Well, when it comes to some of those negative automatic thoughts, right? Those tape loop kind of thoughts. One of the first steps is to think about actually talking back to them. To first of all, identify what you're saying to yourself, because I think often we don't really pause to notice, right? And then we can actually ask ourselves if those thoughts are helpful, right? Sometimes thoughts might even be true, but they may not be helpful, or they may not be useful, right, in the moment. So we think about that in terms of challenging some of those thoughts. These are just examples of some of the ways that we can do that. So I like to sort of think to myself, well, what would I say to a friend? If I had a friend say, oh my gosh, nobody would ever want to be with someone who looks like me, I would say, wait a minute, hold on, don't be so sure, right? What's your evidence for that? I'm not so sure that that's true. We often take for granted when we sort of have our own thoughts, something that we might say to somebody else, if we heard them say it, wait a minute, is that actually true? There might be another way to look at that, right? Isn't that an assumption that you're making? What's with all the shoulds? Maybe we should step back and not say should, but really ask yourself, what do you want to do differently? So again, just give you some examples that the idea about challenging some of those negative thoughts is powerful. And again, I think the point here is that often we do not do some of the kind of challenging with ourselves that we might do with a friend or somebody that we care about. And if we hear them saying something that's sort of automatic and may not be helpful, we might say, just hold on a second. Let's rethink that. So, again, in terms of some of the concrete kind of prompts that we use, this is a worksheet that we give out in some of the interventions that I do, which are literally just questions that you can use to challenge some of those automatic thoughts. So again, just really as a way to sort of check in with yourself. Am I making an assumption? What's my evidence? What would I tell a friend if they said the same thing? Or is it helpful for me to think in this way? And it's interesting, right? When we step back and we look at our thoughts, and we don't just assume they're true, but we actually ask ourselves, is this helpful? Am I jumping to a conclusion? What would a coach or a therapist say, right? What would someone else say about the situation? So again, I think the idea here that we have capacity to be critical of our thoughts, to notice our thoughts, to have a different relationship with our thoughts. So this is something called an automatic thought record. Again, this is something that cognitive behavioral therapists have used for years in all kinds of different situations. This can also be helpful in the context of distress related to sexuality, right? I'm going to just give you an example. So let's say I ask myself, okay, what's my situation? Well, I know that when my partner starts to rub my shoulder, for example, when we're watching TV or we're hanging out, I recognize I have an automatic thought that comes across my head, right? That flies across the screen. Oh no, right? I do not feel comfortable in my body. This isn't going to go well. I feel jittery. I feel stressed. That's an automatic thought I have. Doesn't feel good, right? I'm going to ask myself, what is the emotion I'm feeling right now, right? I might feel frustrated. I might realize it actually makes me feel mad, makes me feel sad, makes me feel a sense of loss, right? I'm not the same person I used to be. And what do I do about it, right? How do I start to realize how these things go in connection? Well, maybe I notice that I always say something like, oh, geez, I'm really tired. Or I get to go to sleep, and I do something to get out of the situation, right? I recognize that what I do is connected to how I feel and how I think in that situation. But what people can do using one of these thought records is to recognize that there might be some other way to go in that situation, right? I might actually notice that I could try something different in my head. I might say to myself, well, I don't know how this is going to go exactly, but it might be nice to have a massage, right? It might be nice to feel close. We may be able to have some intimate touch that is not going to lead to intercourse because I'm not ready to do that, but we could have a conversation about that. And there might be an opportunity to have other ways of just having some connection that feels good, right? I don't know if that's true or not, but you could experiment. The idea here is that, again, it is helpful to be able to notice what the automatic thoughts are, what the emotional connections are, what the behaviors are that they often lead to, and how we might be able to do that differently. All of this is really intended to be freeing, right? To allow us to have a greater repertoire of options, right? Of where we can go. So I'm going to pause for a second and say, those are some sort of core principles that come from what we call cognitive behavioral therapy. Again, very much sort of helping people identify what the automatic thoughts are, what we do with them, and how that sort of awareness can allow us to try to do something different. I will also say that I want to spend a little bit of time now thinking about another perspective, right? All of this is perspectives on thought and emotion and the connection. There is an enormous amount of focus in popular culture these days on mindfulness. I'm sure everybody's hears about that, may be involved in some kind of mindfulness practice. This is a sort of definition that Jon Kabat-Zinn was really one of the main proponents of bringing mindfulness meditation sort of from an Eastern tradition into Western behavioral medicine. Jon Kabat-Zinn sort of really helped concretize that by talking about these sort of four main principles or foundations, which is about, being able to pay attention, being able to listen and observe what's happening in the moment, being able to bring that attention on purpose or with intention to the present moment, being able to focus very much on the here and now, and doing all of that without judgment, right? Being able to do that with curiosity and open-mindedness without judging, right? So that was Jon Kabat-Zinn's explanation for how we sort of think about the main tenets of mindfulness. Now, there have been actually some incredible people who've done some incredible work saying, wait a minute, how do we take that perspective? How do we take that framework and bring that to sexuality, to helping people with sexual well-being, with managing sexual dysfunction, sort of helping people sort of use this in the context of sexuality. So again, I want to just step back a little bit and talk a little bit about mindfulness-based therapies, recognizing that our minds, our brains are constantly generating thought. You could say that it is always in motion. Eastern meditators talk about the monkey mind, right? It is a constant churning jumble of thoughts. Mindfulness-based sex therapy invites us to notice those thoughts without rushing in and judging, just to have an awareness of what's happening without needing to do anything about it. The idea core principle here is that sometimes, in contrast to some of the automatic thought challenging that I was talking about, sometimes thoughts don't have to be challenged, right? We can actually practice, we can cultivate a practice of noticing our thoughts, of allowing them to come and go without actually having to do anything. In some of the work that I do and in both my intervention work and clinical work, we often do exercises that are based on sort of visualization, right? Or mindfulness-based practice where you may notice leaves blowing in the wind or leaves floating down a river. But the idea that, like leaves in the wind or on the river, thoughts can come and go, and that we don't necessarily have to own them, notice them, be harnessed by them or driven by them, but that we're able to just see them for what they are, which is always in motion, coming and going. When we bring our attention to the present moment, I will also point out that we are less likely to be stuck in these thought loops, right, about the past or about the future. That's powerful also when it comes to sexual recovery, right? Being in the present moment and just noticing where we are right now is also helpful from getting us out of feeling stuck. So lots of folks, again, have taken those ideas from mindfulness and brought them to sex therapy, right? Again, also helpful in the context of sexual recovery after cancer. So I'm not going to spend a huge amount of time going through everything on the list, but I want to talk about some of these pieces. When it comes to body awareness, when it comes to just noticing where we have tension or stress in our body, there are a number of really powerful, what we call body scans or body meditations that people can do just to be able to become aware, again, of where we hold tension in our body as a first step to being able to let some of that go. We know that mindful breathing, movement, capacity to listen, again, without judgment, is also useful in the context of interpersonal communication about all of the things that may be stressful related to sexuality. When we think about this from an individual point of view, right, whether that is self-touch, self-exploration, masturbation, whatever we want to call that, being able to approach ourselves in a kind and loving way, again, without judgment, with curiosity, with open-mindedness, can be incredibly helpful for one, again, getting past the avoidance piece that we talked about before, and also bringing us into a place where we are, again, not judging, where we are just being. I think that's incredibly important with sexual recovery around specifically awareness of sensation. We know that so many of our cancer treatments alter how we feel, arousal, sensation. I think a lot about women who have, for example, mastectomy and have reconstruction. People get lots of feedback about how great they look, but they may have no sensation, right? They may not just have loss of nipple sensation, depending on the kind of surgery. They may have an enormous amount of loss of sensation across their chest, right? Front, top to bottom. And that is distracting, right? So being able to figure out where we do have sensation, what feels okay, what doesn't feel okay, really important in terms of sexual recovery. And also this idea of what we call uncoupling, this notion of being able to separate physical sensation from our cognitive capacity to interpret and catastrophize is really helpful. I know that I think Lori Brado is going to be speaking a little bit later in the series, and she's obviously one of the world experts in this, but this notion of being able to reduce physical pain, right, when we also are able to reduce catastrophizing, when we're able to sort of bring a kind of a mindfulness-based approach, we know has a direct impact, for example, on things like intensity and unpleasantness. So again, I want to sort of appreciate that for anybody who's interested in doing some sexual recovery, I think when we also think about that emotional overlay, some of these lessons from mindfulness-based sex therapy can be incredibly powerful in terms of reducing distress. So just to sort of sum up some of what I was just talking about, I think that that increased awareness of that thought-feeling connection is an important first step in terms of creating a new relationship between ourselves and our thoughts. I think this is something that it is incredibly useful for anybody who's gone through major changes in body and sexuality and is really trying to figure out what a new chapter is going to look like. I would encourage anyone to sort of look into some of the kinds of exercises that I talked about. It's interesting, since the pandemic on YouTube, there is a plethora of really high quality mindfulness-based exercise, both in terms of general, for example, body scan and progressive muscle relaxation, and also more specific such as pelvic floor relaxation, which is sort of learning about how to identify tension in our pelvic floor and what are kind of some exercises we can do to reduce stress, including stress in the pelvic floor, and promote awareness of that. And again, I think the point here is that these sort of mental and physical exercises can really help people move out of that avoidance anxiety cycle and really set us up for trying new experiences and really creating a new chapter. I want to talk for a few minutes about sexual desire, because I think that this is something which is incredibly distressing, and it is really at that intersection of sort of physical and emotional components. When we think about a sexual well-being, it's probably the most common concern or distressing concern on the other side of cancer treatment, which is low desire. I'm going to talk a little bit about female sexual desire because this is, again, sort of super common. We know that most of the time, the experience of desire is no longer automatic, especially as we move into midlife, when we've had major physical changes after menopause. It does not work like a light switch where you either have it or you don't. We know that the motivation for sexual activity lots of times simply does not feel spontaneous the way that it might have, before cancer. But we also know that desire really, for most women, actually emerges out of an experience that feels good, that feels sensual, that allows people to feel emotionally connected, or that feels arousing. That actually desire is an experience that we have to create or cultivate rather than we expect to just have it or you don't. I will say that the name for that is called responsive desire. And I like the metaphor that a patient actually shared with me not too long ago when we were talking about this. She said, "Oh, it's like toast." And I said, I'm not really sure I understand what you mean. And she said, "Well, when you put bread in the toaster, it really has to warm up before it pops." And I thought, yeah, that's another way of thinking about it, right? It's something that we don't expect to be spontaneous, but we have to cultivate. So what does that mean? I want to give you a couple of examples that I often find helpful. I'm thinking about that delicious, rich smell of that chocolate lava cake, which, I don't know about you, but lots of times I'm thinking about if you're, for example, you go out to dinner with friends, you've had a nice meal, you're really full, you're not hungry anymore, you've had a really delicious dinner and it was just fine, except for then a waiter walks by with that lava cake, and all of a sudden you notice that your sort of your palate has been piqued and your mouth is watering and it smells delicious, and you think, actually, I could have a bite of that, right? That it wasn't that you started out with being hungry, but that you sort of noticed or smelled or had a kind of a sensual awareness or arousal, which then sort of prompted you to feel all of a sudden a little hungry, that you could have a bite of that. The other example that I use often really has to do with exercise when I think about responsive desire, meaning that often it is the case that people do not spontaneously feel in the mood to move their body, but it is actually after we actually start to move that we feel a little more energized, that we feel more awake and alive, and that's what motivates us to keep going. So again, point being here that desire is often an experience that needs to be cultivated. It is not automatic. We know that it is normal that people need support, right, to get things moving. So whether that is a fantasy, a memory, erotica, something that feels good, again, I don't think that is unusual at all, that we often need some material to react to, and that it can be really helpful to replace that idea of spontaneity with anticipation. And I say this because I think in popular culture, all of our examples around desire are absolutely based on how it looks when you are 25 and first dating, right? Every movie, every TV show, every billboard, it is with this idea that desire is supposed to be spontaneous. And that is, for again, most women, absolutely not the true. And I think in particular after cancer, that may really mean developing, cultivating new habits, new scripts to really sort of cultivate this experience. I will just pause and comment that I'm sort of talking about lots of the emotional cognitive perspectives on this. for anyone for whom sexual activity is uncomfortable, uncomfortable physically, right? Whether that's vaginal dryness or pain, discomfort, really important to address those issues. Again, I know you have other speakers in this series that will specifically talk about those things, but I feel very strongly that, all of those, the physical pieces need to be put in place 100% in order to be able to go on and do some of this other work. But again, I think that often it is not one or the other, right? Even if the physical pieces are in place, we still have to deal with the sort of emotional, motivational issues around desire. And together, that is often what can really create a new and more satisfying chapter. Couple of other things I'm going to comment on before we stop, because I really just want to appreciate that around this kind of emotion, thought, feeling work, it is not, I don't want to take it out of context. I appreciate that. There's often relationship work that has to be done related to emotional distress. I appreciate that couples often really struggle with how to talk about this. There are changes that feel stressful. I think for most couples, there is really a need to refocus on what is pleasurable, what feels good, what is sensual. That may look very different than it used to be. I think it's helpful to think about starting slowly without being goal-oriented. I think in general, whether you're talking about you're doing this for yourself or with a partner, broadly speaking, I think we have to really expand the repertoire. And I really would encourage people to get support as they need to. And again, just making the point here that the relationship work is part of it, right? And if there is emotional distress related to issues in relationships that feel like it's hard to communicate or hard to talk about, or people feel guilty or people feel frustrated, that may actually mean doing some interpersonal work as well. And then the last thing I really want to also just acknowledge, related again to emotional distress, is body image and the perception of feeling whole, the experience of what it is to feel whole in our body after cancer. It is not obvious. I think that we often don't give people the support they need for this, but I really want to just make a couple of points or thoughts that I have, which is that first of all, in general, body image is not necessarily driven by any one body part. We are not defined by any one body part. I think it's really important to learn how to cultivate compassion for ourselves and our bodies. Again, thinking back to some of that non-judging awareness or exploration. We are often so much more compassionate to others than we are with ourselves. And I think we have to cultivate kindness, right? In the context even of loss, of change that may be permanent. And I think much of the antidote to some of this, not perfect, but something that can often compensate, is to really put a focus on what our bodies can do, to regaining a sense of strength and reimagining kind of a new chapter around function and strength in the context of some of these changes. But again, appreciating that changes in body image and that sense of body integrity is also emotionally intense. And I think it's important to get help for that if that's something you're struggling with. So, I would say in closing, thinking about the sort of emotional distress piece, like anything else, I think it's important to acknowledge the changes, and to really identify the goals that you might have. I think, I often think about that sort of emotional reset or reboot, really like any other dimension of survivorship. I think it's something that we have to focus on, again, for its own sake, and to take the time to be really curious, right, about pleasure and sensuality and all of the ways that sexuality has changed, recognizing that it can bring up feelings of worry, of distress, that we can tolerate some of that. We don't have to avoid it, but we really can choose and commit to a plan, right? A plan of action and a plan of recovery. So that's what I wanted to share with you tonight. I'm very happy to take questions and have some Q&A. And thank you, Jennifer, for having me.
That was so amazing. Thank you, Dr. Bober. We're so grateful for this incredible presentation and so many new ideas that we haven't heard from any of our previous speakers. So thank you. I do want to invite, if folks want to put questions in the chat, or even if you want to pop off mute, certainly we welcome you to do that. We did have a question about slides. We're not going to post slides, but the presentation will be posted with our other presentations, and we'll send out a link to it when it's ready. So you'll be able to find all of the information there.
But sure, very happy to take any questions. And again, given that we are not doing a webinar, if anybody wants to unmute themselves and to ask, I'm happy to chat. Or not.
Well, I'm curious, just given you presented so many incredible interventions and ways that people can think about their sexual health and well-being and get back to that. And you also mentioned flexibility. So I'm just wondering, like, how long do you typically work with people, or how many different methods or ways that people try as they start to kind of see a difference or see some shifts?
I think what's interesting, when I've really noticed, Jennifer, is that, it is not one-stop shopping, right? Sometimes some sort of a little bit of ongoing counseling can be incredibly helpful. Sometimes, 2 or 3 or 4 sessions with someone that can help you really sort of focus in on something that you're struggling with is enough to really allow you to kind of have a plan and try something different and kind of move through some of that avoidance or anxiety in a way that's very powerful. So, the longer I've been doing this work, and as you know, I've been doing this a long time, I don't think that it is always about, and again, I say this, I was very psychodynamically trained and I love psychotherapy. I don't think people necessarily have to have ongoing intensive psychotherapy, right, to address some of these issues. I think that sometimes, sometimes it's helpful, right? I mean, sometimes, I see couples, I often see people in clinic, and this happened again today, where, I was meeting with someone who was telling me about a certain frustration. He was 75, but what became clear is that the problem started after his wife had a baby and they stopped having sex regularly 45 years ago, right? So people live with all kinds of, changes and stress or distress that is not like horrible, but not great for a really long time. And then often, when there's a major stressor like cancer, that kind of pushes things over the edge, and then people are really struggling. But when you kind of look into it, you realize like there may be some issues here that have to get figured out that didn't just start at your diagnosis, right? That but maybe need a little bit of work, or that might be a couple that needs a little bit of help communicating about something that they hadn't actually really worked out exactly for a long time before cancer. So I think that that's variable, but what I would say is that the kinds of I think the kinds of strategies that I talked about today, we know that they work, right? We know that help is available, and I would just say that people don't have to suffer, right? I would say that and we all sort of appreciate that, but in reality, often what I'm struck with is that people often kind of assume that, as I said, some of these things are sort of the price I have to pay, when there's often really there's room there to make things better.
That's great. We had 2 really nice questions come in. One, moving beyond avoidance, tolerating distress and discomfort to get to reframing self-talk. How do you begin to tolerate distress and discomfort?
So, what I would say is that even just sort of knowing, right, that there's going to be some anxiety or distress is useful, because all of a sudden, when you start to feel some feelings, you can go, oh yeah, I know you. I'm expecting you, right? It isn't something that you immediately have to do anything with. I know that, and I think Lori Brado is going to come and speak with you at some point, and she's really one of the world's experts around mindfulness meditation. And the fact is, part of why people often have a mindfulness practice, right, where they do some kind of regular practice, is actually learning, right, or practicing literally how to be able to just sort of sit with feeling. Right? I mean, we live in a culture that is completely built around avoidance, right? Everything in this culture is built around distraction and avoidance, right? Just be happy. If you're not happy, do something louder, faster, different, whatever. And that is very different orientation to being able to just notice, right, that I'm having some feelings, and I'm noticing that actually it is not going to kill me or make me crazy or make me go blind, but that I can actually just sit right now and feel what I'm feeling. and it's actually okay, right? I can do this. And it is, you know, it's really, you can extend that interpersonally, right? Where we imagine that if I say to my partner, you know, this has been something that's been on my mind, is it okay to sit and talk for a few minutes about this? I just have a lot of feelings. I miss how things used to be. I know they're different. It makes me nervous to bring it up, but is it okay to talk about that? People are often just shocked when what they get back from a partner is, oh my gosh, I've been thinking the same thing. I I'd like to do that too, right? So sometimes what we anticipate is not what is actually what we imagine, and also, you know, that feeling of you know, tolerating distress. Part of it is just what we call exposure, right? Part of it is just actually putting a toe in the water, right? And just noticing and saying, I'm going to just sit for 5 minutes and see what happens. Right. So it's not about, we're not talking about diving into the deep end of emotional distress, right? We're talking about a toe in the water approach where we just, you know, and this can extend to all kinds of things. This can be about, you know, patients who say, I will avoid ever seeing myself naked in the mirror because it's so upsetting. And I would never say to somebody to do something they don't want to do. But on the other hand, it may not be what you imagine, right? So is there somewhere between all or nothing, again, that black and white perspective, to say that I might be able to notice something in the shower, I may be able to tolerate looking for a moment and just seeing, right? Again, there's room to play with this, but the idea here is that very few things are all or nothing, and I think being able to sort of have a practice where you can cultivate, again, kindness, compassion, empathy for oneself can be really helpful.
Great. Someone else asked, and then a few other people hopped on. Do you have any specific advice about feeling angry about sexual health changes?
I mean, feel angry. You know, I honestly, like, I'm big on letting people feel what they feel, right? I would invite you to, you know, the idea of like, what do you do you have any advice about, you know, feeling angry? Like, I'm not trying to say that the goal is to be angry, but what I'm saying is the goal is to give yourself permission to feel your feelings. You know, I mean, my big issue in survivorship, and I've been in this field again a long time, is there is so much pressure to be grateful to be alive, to be grateful to be a survivor. I don't think we actually give people enough reassurance to say it is normal to feel profound distress, right? Profound sense of loss. My friend Daniela Whitman talks about grief. I think that's a very real feeling, right? When people go into menopause, when people lose body parts, when people do not have the same capacity or function that they used to, you know, I don't think it's a great idea to put yourself under the pressure that you're not supposed to feel negative feelings. I think negative feelings is part of feelings, and that's all normal. So, you know, ironically, or I would say paradoxically, you know, when people give themselves permission to feel all the feelings, often they come and they go, right? It's actually easier, right? It's to sort of notice that you can be frustrated or sad or angry for a few moments, and then when you actually feel the feeling, then you kind of see it wane and you move on to the next thing. It's really when we are paradoxically are telling ourselves that we're not supposed to be mad, that we end up often sort of being in knots inside. So I don't know if that answers the question, but I that's really a big part of where I'm coming from on that.
A lot of people relating to that, so that's great. Well, good. Thank you so much, Dr. Bober, for being here. Thank you to all the participants who were able to quickly hop over here. There's a link for feedback on tonight's presentation, and as I mentioned, we'll have more speakers who are coming up, and a link to the video will go out shortly, but really grateful for all that you shared tonight. I know there were, someone said aha moments, and I think that was really true. There are really a lot of moments to kind of pause and say, hey, can I think about this differently? So thank you for sharing your wisdom with us. Thank you for being flexible. And
thank you for having me. Thank you for having me. And I appreciate being able to do this talk with all of you tonight. So thanks, Jen.
Thank you.
Good night.
Good night, everyone.